Hi, everyone. Thank you so much for having me. Um, so my name is Ishaan Desai. I work as a research assistant to Dr. Paul Farmer, who is a physician and a medical anthropologist who co-founded the nonprofit Partners in Health, which some of you may know. If you don't, it's an organization that seeks to deliver high quality medical care in places that are burdened by extreme poverty and very weak health systems. And so PIH initially began working in a very rural part of Haiti in a community of dispossessed farmers. But in the ensuing decades, we would go on to work in many other countries. So other parts of Haiti, but also Peru, Russia, Rwanda, Lesotho, Malawi, the Navajo Nation. Actually, I think the next slide should indicate that. Oh, there you go. So I was trying to remember them from memory, but so yeah, Rwanda, Lesotho, Malawi, Kazakhstan, Mexico, and then more recently Liberia and Sierra Leone in the wake of Ebola, and of course now in the United States in response to COVID-19. Next slide. So so yeah, as I was kind of listening to Dr. Mina's comments and reading kind of the latest iteration of this article, I was really struck by how this particular issue, this kind of this very common sense approach to a comprehensive response to COVID-19 has been met with some kind of resistance, and this kind of unfounded resistance to rapid coronavirus testing, to me, has really kind of mirrored a lot of the false dichotomies that have long patterned social responses to epidemics and pandemics. Rather than trying to seek to bring the full might of both modern science and public health, or as Dr. Mina said, the full arsenal of tools that we have to bear on the greatest health crisis we've seen in over a century. We've fallen into this common habit of trying to pit interventions against each other. All right, so you either PCR or rapid testing, rapid antigen testing, or you know statements like if we introduce rapid testing, then we risk doing more harm than good because of XYZ concerns. So I'm really just deeply grateful for the leadership of Dr. Mina and the entire rapid test team for the brisk advocacy you've undertaken to integrate rapid testing into a very comprehensive approach to COVID-19. So I'd like to kind of reflect on the work that's presented in this article by recalling what I and many at Partners in Health consider one of the biggest barriers to health equity, both here in the US and globally, and that is a failure of imagination. So I'd like to frame my comments around this quote from Dr. Farmer, who wrote, "Failures of imagination are the costliest failures. When the iron cage of rationality leads to a poverty of imagination, cynicism and disengagement follow. True accompaniment does not privilege technical expertise above solidarity, compassion, and a willingness to take what may seem insuperable challenges." Next slide. Yeah, so I'd like to kind of describe what I mean as this barrier to health equity through a couple of cases that PIH in particular has been involved in over the years. So the advent of antiretroviral therapy in the mid-1990s was groundbreaking for many reasons. Of course, most importantly for the way it converted HIV or HIV disease from a death sentence into a chronic infection that could be well managed with proper care. But even as the therapy was rolled out with great enthusiasm in places like the US, there was a kind of lethal failure of imagination when it came to delivering this new innovation in settings of poverty, especially in sub-Saharan Africa and the Caribbean. So I'd like to kind of just illustrate this with these two quotes. In 1998, the head of the HIV/AIDS division at USAID said, "If we used antiviral drugs and treatment regimens similar to those used in the US, it would cost approximately 35 billion per year to treat those infected in the developing world. How can we get involved in care in the face of such staggering statistics?" And likewise, public health experts writing in the Lancet pointed out through modeling that data on the cost effectiveness of HIV prevention in sub-Saharan Africa and on highly active antiretroviral therapy indicate that prevention is at least 28 times more cost effective than antiretroviral therapy, and that the next major increments of HIV funding in sub-Saharan Africa should be devoted mainly to prevention. So, I think this is in many ways reflective of these kinds of false dichotomies that we're seeing now, even around the testing debate, and that groups like Rapid Tests, are trying to debunk, which is this idea that we need to make either or choices in the midst of a massive emergency, right? Next slide. So yeah, so so Partners in Health has tried to counter such failures of imagination. In 1998, we launched the HIV Equity Initiative, meaning not me, I was 6 years old at the time, but our founders and our whole team in Haiti launched the HIV Equity Initiative to provide antiretroviral therapy to patients living with HIV. And it was really a community health worker-led model, a very community-based, home-based approach, similar to what's being advocated here for rapid testing, really to try to decentralize services at kind of the home level within communities where people work, where people pray. So Partners in Health, ran this program, treated an initial set of 50 patients before expanding to a much larger cohort, and ultimately proved that the integration of HIV prevention and care was possible in rural and poverty-stricken settings. And the graph that you see on the right is just a description of what the impact of this work has been as a result of kind of worldwide activism for expanded treatment access. So you see AIDS deaths declining throughout the decade from 2002 to 2012 as the number of people receiving ART increases. Next slide. So another kind of failure of imagination is related to cholera in Haiti. And 10 months after the earthquake that struck that country in 2010, PIH turned its attention to another crisis, which was an explosive epidemic of cholera, which was, until recently, the world's largest cholera epidemic. What was especially striking at the time was kind of this either or argument that we're seeing now with COVID, which is, we had licensed cholera vaccines that had been proven both safe and effective in clinical trials. And they would ultimately remain unavailable to the majority of patients for several years into the emergency. And when colleagues at Partners in Health advocated for a more comprehensive approach to cholera treatment and prevention that incorporated vaccines, they were often met with bitter disapproval and dismissed as kind of unrealistic. Some would say that it's too expensive in resource-limited settings. Others pitted vaccination against other kind of control measures. So like, oral vaccines would divert attention and scarce resources from water and sanitation projects. Again, this is without really any sort of empirical backup. Next slide. So yeah, PIH sought to, again, counter this failure of imagination by building a program to deliver 2 doses of oral cholera vaccine to people in rural Haiti. And again, this was at a time when many policymakers considered cholera vaccination unfeasible or a distraction, and PIH's efforts helped to demonstrate that comprehensive cholera prevention and treatment, including vaccination, were possible and that they were actually synergistic. And so this would end up kind of shifting international health policy in many ways and catalyze the creation of a global vaccine stockpile, which has since distributed millions of doses in cholera outbreaks around the world. So as I've tried to show, promoting health equity requires that we try to interrogate confident claims that are often advanced to exclude many people from the highest standard of care. And these are almost always people who are marginalized by poverty inequality, racism, gender inequity, and other social forces. So in this kind of third example, in the case of Ebola in West Africa, which quickly became the largest recorded Ebola epidemic in history, there was often a great deal of confidence about Ebola's high case fatality rates, and it often went unquestioned, which led to very kind of substandard medical care and fueled quite a bit of resistance to any attempts to actually improve the quality of care delivered to patients in West Africa itself. Facilities that were meant to care for Ebola patients usually prioritized isolation and containment, but they offered very little in the way of treatment, as you can see in this kind of grim photo of an Ebola isolation unit in Liberia. And then one logistician working with Doctors Without Borders, just to cite one example, said, with a mortality rate of up to 90%, we know that most people in the treatment ward will not come out. We do the most we can for them. Whatever the patient wants, the patient gets. Special food, new items of clothing. It's easy to do and it does them good. So, I mean, there are many aspects of this that I think are problematic, but if Ebola is indeed almost universally fatal, then what explains the kind of shocking inequity that's shown in the graph on the right? You can see that mortality in a cohort of Ebola patients who were treated in West Africa was over 70%, but among American citizens treated in US hospitals, it was 0%, none died. In other words, in settings in which high quality supportive and critical care can be provided, it's very clear that Ebola is not a death sentence. It's eminently treatable even in the absence of specific antiviral therapies. Next slide, please. Yeah, so when Partners in Health launched its Ebola response in Liberia and Sierra Leone in 2014, narrowing this disparity of outcomes that we just talked about was a central goal. And that meant elevating the quality of care and integrating preventive and therapeutic approaches rather than kind of pitting them against each other, as we've seen with AIDS, cholera, and now also Ebola. And then kind of more related to the kind of the discussion of rapid testing, any attempt to achieve equity of outcomes also demanded, in the case of Ebola, a much more robust commitment to testing, diagnosing, and just introducing robust laboratory capacity. So in Guinea, Liberia, and Sierra Leone, where most of the cases were registered, there were very few laboratory facilities. They were effectively diagnostic deserts. In fact, at the start of the outbreak, there was not one laboratory in the entire region that was able to perform an RT-PCR test for the Ebola virus. So health authorities would invariably fail to identify the virus as the cause of infections until months after the outbreak already began. And even then, that only happened once samples were shipped north to laboratories in France. And I think as the epidemic wore on, there was kind of an increase in diagnostic capacity, but a lot of it was very centralized and concentrated in specialized biosecure labs that were often very far from kind of the main Ebola hotspots, which meant that patients would have to wait many days and even over a week to get results, not unlike what we've seen with kind of COVID over the past year. So obviously this has very dire implications for further transmission, for triage, for infection control, nosocomial spread, and of course, clinical care for patients. So it wasn't uncommon, for example, to have a patient die before the Ebola test came back positive, or conversely, to get infected in an Ebola ward, even though you may have been free of the virus prior to admission to the ward. So to help kind of improve this delivery problem, Partners in Health was involved in conducting field validation studies of 2 rapid diagnostic tests for Ebola virus disease in the midst of the epidemic itself. So one on the top left here was a point of care rapid antigen test, and the other was an automated molecular test using the Gene Expert system by Cepheid, which, as many of you may know, is frequently used to diagnose TB and other diseases. Both rapid tests demonstrated high sensitivity and high specificity in comparison to lab-based RT-PCR tests that were kind of more conventionally used to diagnose Ebola. And In this case, while the studies were conducted a bit too late into the outbreak to have had kind of widespread adoption outside of the research protocol, they've certainly paved the way for much faster detection of cases and initiation of therapy in future epidemics. So for example, in the DRC, the gene expert test has since been adopted as the primary diagnostic, the first diagnostic that's used for Ebola or suspected cases of Ebola. And it's likely to be used, of course, in the recent outbreak in Guinea now as well. So, I mean, just from the DRC example, it was evident that it reduced turnaround times to just hours rather than days or even weeks, and allowed for, therefore, much prompter initiation of treatment and isolation, and now also vaccination and tracing of contacts of those who test positive. So, and of course, now we also have kind of specific therapeutics for Ebola. And their utility as well depends on prompt testing. So there was a clinical trial that was conducted during the epidemic in DRC that started in 2018. And there were, two monoclonal antibody based therapies that were found to be very effective in reducing mortality, but especially so among patients who were diagnosed and treated early, while their viral loads were still low. Mortality, I think, was somewhere around 10% in this subset of patients. A huge improvement compared to the 70% figure that we saw in West Africa. Now, of course, not all patients had access to prompt diagnosis and treatment, but I think what this example of Ebola shows is that rapid testing, whether for Ebola or for COVID, if linked to an equity plan and a preferential option for those who are at greatest risk of infection and illness, can just play an enormous role in reducing health inequities. To me, what's being advocated in this paper and by this entire group is a commitment to equity. And that means, again, trying to push forward a much more imaginative idea of what's possible. I think there's been a lot of kind of containment nihilism in this country where people have kind of just given up on what's needed to stop the epidemic, and have kind of just counted on the vaccine to ultimately be our savior. And at this point, obviously we've had a fairly mediocre rollout of the vaccine so far, and at the same time, as many people in this group have said, it still remains to be seen, how much, what level of coverage we'll obtain. And so in the meantime, a failure to act and to implement this, this strategy of rapid testing at scale will unfortunately mean many more lives. So just briefly on PIH's COVID work. So, we have recently begun working in both, in all of our sites around the world, but also more substantially here in the US. In April of 2020, we were invited by the Commonwealth of Massachusetts to stand up the Massachusetts Community Tracing Collaborative for COVID-19, which is a contact tracing program, where we kind of drew on lessons after we learned from Haiti, Rwanda, and Sierra Leone, Liberia, elsewhere, to fighting other epidemics, to build out this tracing program, and at the same time try to build care and accompaniment into it. I think a lot of times people think of tracing as a surveillance strategy, but we've tried to really frame it as one of care, in that you may trace a contact, but in order to permit, for example, safe isolation, if you're a case, or quarantine if you're a contact, you may need resources. You might need social support. You may need food. You may need housing support. And so this has been a pillar of PIH's approach. Now, that said, there's tracing is so reliant on prompt and accurate testing, and so I think that there's just a massive need and a massive area in which the rollout of rapid tests at a much larger scale can actually amplify the utility of something like contact tracing. And so again, I just want to express my admiration. PIH actually from the start has elevated both PCR testing for clinical diagnosis as well as rapid testing for the reasons that have been mentioned. And very early in the epidemic, our leadership was committed to um, procuring hundreds of thousands of rapid diagnostic tests, including antigen and antibody tests for use in 8 countries around the world. And I think it's also important to remember that in a lot of the countries in which we work, there's maybe only one national laboratory in the entire country that could do a PCR test. And that was certainly true at the beginning of this outbreak or pandemic, and still true in many places. And so it was clear that we would have to integrate other strategies in order to get kind of a handle on what was going on, trying to even start to understand the epidemiology of the virus in places where it just hadn't been detected before. So I've linked here, for example, a COVID triage and screening diagram that I think to the delight of people in this group, endorses rapid antigen testing. And our laboratory colleagues, led by Daniel Orozco, Nidia Correa, Megan Striplin, and our network around the entire world, has really kind of elevated the importance of both support for RT-PCR for national laboratories and use of rapid diagnostic tests in more kind of community and clinic-based settings. So yeah, I just want to close by saying, what we faced here is a failure of imagination, and that's the biggest threat to health equity. And I think that the work being advanced in this paper and by this group, if it's adopted at scale, it can really have an enormous impact, not only in containing the epidemic, but also starting to close a lot of these health disparities that the pandemic has unveiled. So thank you so much.